chromosome 9 short arm, region area 2-1, where we have a gene called P16. And this gene is usually altered in patients who have HPV infection. So as the disease progresses, then there will be a mutation in chromosome number 17, especially where we have a gene TP53. And there's overt squamous cell carcinoma, where we have mutations in chromosome number 11, especially where there is a gene regulating the cyclin D, and many other areas, chromosome 4, 6, 8, 13, and 14. So this is in general what we see in squamous cell carcinoma of the oral cavity. I think you remember that we saw almost a similar picture in the cancers of the intestines. So maybe the picture is not here clear, but it is a squamous cell carcinoma of the floor of the tongue here. And the cancers of the tongue usually they arise from here, the floor, not on the dorsum part of the tongue. They are here on the floor of it. And here we have another disease. What you can see here on the right side, you see this person has 4 teeth, and the other teeth are no longer seen here because they have been destroyed by a tumor of the mandible. So leukemia, as I had mentioned somewhere, leukemia, as you know, it is a cancer of blood-forming organs, meaning it is seen in the blood itself and in the bone marrow. It is characterized by rapid growth of immature white blood cells. It can be even red blood cells, immature ones. Oral symptoms of leukemia may be some of the first indications of the disease. That's why when I started, I said, when you see, for example, hyperplasia or swelling of the gums as in this patient, you should not say this is just simple thing. You must think beyond what you see as a scientist and think maybe this person may be having leukemia. Then you do examination properly. So the symptoms may be gingival hemorrhage. Yes, most of the patients with leukemia, they come with hemorrhage. Enlargement, spongy texture, ulceration, and magenta coloration of the gingiva. It is not only enlargement, it will be a spongy texture. Spongy, it means if it's a sponge, it is a sponge. You sometimes ulcerated, and the color is magenta or brown. Someone is talking in the background, please. Can you mute yourself if you are not interested? So other manifestation will be enlargement of lymph nodes, symptoms of anemia, general genesis. This patient, because they have low platelet counts. So the issue of the smokeless tobacco, it means chewing and the other types of tobacco. These are serious health hazard because they are the ones causing oral cancers, squamous cell carcinomas. So they are associated with high rates of precancerous leukoplakia and oral cancers occurring in most users of smokeless tobacco. Cancers of the pharynx, larynx, and esophagus occur 400 to 500 times more frequently. You understand the risk of tobacco. So it means among 500 patients of esophageal cancer, larynx, or pharyngeal cancers, only one of them will be a non-smoker. Others will be smokers. Smokeless tobacco is also linked with an increased incidence of tooth loss from periodontal diseases. They used to have abscess and the other diseases around the roots of the teeth. Dental implications of radiation therapy. Also, if someone has received radiotherapy around the neck or around the head, so this may have as a complication some problems in the oral cavity. So the first one, patient will have xerostomia. So the mouth will be dry. Another is radiation caries because there will be no saliva. So usually it appears facing the cervical areas of the teeth. The teeth also may become extremely sensitive to hot and cold stimuli. So this is what we call radiation caries. Another is osteoradionecrosis. It means there is necrosis of the bone after radiation treatment. And here the problem maybe there is a bone which is necrotizing, and therefore if it is necrotizing ariho amenyo yafataga, then amenyo azavamo atakaza amenyo because of that. So that is in general what we can say about cancers in the oral cavity. So the most frequent is squamous cell carcinoma, and if we saw the pathogenesis, and the other cancers such as leukemia, they have oral manifestation, but leukemia is not a disease of the oral cavity per se, but it has oral manifestation. And also because cancer is treated with different options, including radiotherapy, that radiation may cause a lesion, some lesions in the oral cavity. So other cancers, as I said, we cannot cover all the diseases. We have, for example, in children, we used to have rhabdomyosarcoma arising from the skeletal muscle. And of course, as I said, we have carcinomas arising from the salivary glands, minor salivary glands. We have not listed them here because we discussed them last time. So there is no difference between those cancers, whether they arise from the major salivary glands or minor salivary glands. They will appear the same histologically. So no need to repeat them again, but you must keep in mind that they exist. So the acquired immunodeficiency syndrome, it has oral manifestations, as I had said, and these oral lesions are prominent features of this syndrome. Oral lesions develop because of the breakdown of the immune system that occurs when T helper cells, which you know they are CD4 cells, they become depleted because of the disease. Because HIV/AIDS, the virus itself, it attacks these CD4 cells and it kills them, or causes them to be killed. So the patient's immune system is when it is severely damaged, it will be followed by death, and this death is usually caused by opportunistic infection. So you cannot say HIV/AIDS itself kills. What it kills are these opportunistic diseases, the cancers, severe infections, and so on. An opportunistic infection is one that normally would be controlled by the immune system, but that cannot be controlled because of HIV/AIDS. The immune system is not functioning properly. So you will see that in most of these opportunistic diseases, the cause is just a normal floral agent. A normal floral agent, but because the immunity is too affected, the immune system will not be able to control this for normal flora. Therefore, they will cause diseases. So this is what happens in most of, for example, gastrointestinal tract infections, such as toxoplasmosis and so on. They are a normal flora, but when immunity is too much damaged, they will cause severe disease. It is important to remember that some of the lesions that look like HIV and AIDS-related infection may also be caused by other disorders. So that's why some opportunistic diseases may be seen in diabetes, not in HIV, because diabetes also affects immunity. So the first one as opportunistic disease is the gingivitis, HIV-associated gingivitis. So you understand it is inflammation of the gingiva. It is also known as atypical gingivitis. In some cases, there may be progression of the bright red line from the free gingival margin over the attached gingiva and the alveolar mucosa. So it starts at the line at the border of the free gingival margins, meaning where the gingiva aho ubona ihurira n'amenyo. Niho ashaka kuvuga. It starts there, but it may progress to other areas. There is also periodontitis. It resembles acute necrotizing ulcerative gingivitis superimposed on rapidly progressive periodontitis. So the symptoms include interproximal necrosis and cluttering, marked swelling, intense erythema over the free and attached gingiva, intense pain, spontaneous bleeding, and bad breath. So these are some of the signs of this periodontitis. So araribwa cyane in difference to gingivitis, although it may be painful, but when the disease affects the teeth, especially around the roots of the teeth, it becomes very painful. Another opportunistic disease is the Hiv Cervical Infertinopathy. As I said, when someone is infected by HIV, they start by having flu-like syndrome, flu-like symptoms. After that, these symptoms will disappear. Then the CD4 cells will start to be depleted from the body. When they are too much depleted, the person will develop cervical lymphadenopathies, or generalized lymphadenopathies. But here we are talking about the cervical ones. Otherwise, the patient may have lymph nodes enlargement in the inguinal, cervical, axillary areas, and even around the visceral organs. So lymphadenopathy is frequently seen in associated with HIV. So when you see a patient with non-explained lymph nodes, you can think of doing tests, HIV testing, because this may be a first manifestation of HIV in that patient. Otherwise, when someone is having, for example, inguinal lymph node, usually it will be due to a wound somewhere around the legs or around the buttocks. And when there is a lymph node enlargement in the axilla, you can look to the breast or on the upper limbs and so on. So if no lesion is seen around there, then think about a systemic problem such as infection by HIV. So HIV lymphoma, it doesn't cause a lymphoma, but it causes a weakening of the immunity, and thus cancer may develop very easily. Among these cancers which are associated with HIV, there are lymphomas, there's cervical cancer, there is Capacitor, Coma, and others. So this person, as you see, is having a lesion in the oral cavity on the tongue here, which is like refungating, black. Some areas are blackish, others are just brownish. It is not well circumscribed. It has irregular surface. So this may be, it can be squamous cell carcinoma, it can be in infection, but least likely, or it can be a lymphoma. So a biopsy will confirm what it is. And it is important to know that it is necessary to know what is the type of disease before you go for surgery. Because the lymphoma, if a patient is having a very large tumor, it is lymphoma, and you do surgery on it, that patient will die. Will die in a short time. But if it is a carcinoma and you do surgery, that's fine. It will be a mode of treatment. So lymphoma is not treated by surgery. So that's why it is always good to start with a small biopsy, incision biopsy, to have a diagnosis, and then you decide if you go for surgery or for other modes of treatment. So in the immune-compromised individuals, a lymphoma will occur as a solitary lump or nodule, as a swelling or a non-healing ulcer that occurs anywhere in the oral cavity. So it can be on the tongue, on the floor of the mouth, and so on. The swelling may be ulcerated or may be covered with intact normal appearing mucosa. It is usually painful. It grows rapidly, and it may be the first evidence of lymphoma, because this patient may be having a larger lymphoma somewhere else, and they have its counterpart in the oral cavity. So hairy leukoplakia, we have mentioned it before, but it is also one of the opportunistic diseases in cases of HIV/AIDS. So Kaposi sarcoma, so it was discovered by someone called Kaposi, and it is a cancer caused by a virus called human herpes virus 8, human herpes virus 8, HHV8. So yeah, you see it below the ear, so infra-auricular area. Here it is on the gum or gingiva, and so on. It can be seen anywhere, on skin, in the oral cavity, in the genital organs, in the eyes. So we see it in many areas. But so far, there are many types of Kaposi sarcoma. The first one is called endemic. Endemic, it means it is caused by other things, not HIV. And there is the one which is HIV associated. Some people, they call it epidemic. So endemic is something which is there, and it is seen in a few cases per region. But when it is called epidemic, it means there is an increase in the number, in the incidence. So one is HIV associated, another one is endemic. So HIV associated, it is usually called the African, because this type of cancer of the HIV is more seen in Africa, while the endemic one is seen in European countries and North America. So on the morphology also, it has many types, stages. So stage ya mbere ya Kaposi sarcoma uzabona kameze ko ariko ari akantu kameze nka plaque. So it is not a very nodular. It is just a discoloration. Then nitinda usanga yazamutse raise the surfaces, and as it stays for longer, it becomes a nodular, like what we see here on the gum. So nodular stage is the last stage of this disease. And you understand, for treating this one, if it is advanced on nodular stage, it will be more difficult to treat as compared to the plaque or patchy stage. So there is no effective treatment for Kaposi sarcoma, ariko ikikunda kubaho nuko nka mu Rwanda dufite iyo umuntu ayifite afite HIV, iyo umuhaye imiti ya sida akenshi n'iyi cancer itangira kugabanuka. So it's one of the intraoral regions that are used to diagnose AIDS, meaning it is when a person infected with HIV develops Kaposi sarcoma, automatically we say he or she is now on AIDS stage. So herpes simplex virus, it causes lesions on the lip. I think I have mentioned this, that when it is a virus, almost everybody may have it, but it doesn't cause lesions in all people. But when affected area, especially so an ulcer caused by the herpes virus that persists for longer than 1 month could be an indicator of AIDS. So then you understand that when you have a patient with such a condition, you should test for HIV. If he's HIV then positive, then you confirm that he's or she's entering into AIDS stage. So human papillomavirus, it affects not only anogenital areas, but it can affect also oral cavity. And the serotypes, the serotype HPV 16 and the 18 and the 53 and 58 and others, other high-risk HPV viruses, as you know, they cause cervical cancer, penile cancer, vaginal cancer, anal cancer, squamous cell carcinoma, and these same serotypes also they cause oral and pharyngeal or squamous cell carcinoma. And what you have to know here is that when you have two patients with oropharyngeal squamous cell carcinoma, one is caused by tobacco smoking, another one is caused by HPV. The one with HPV will be treated differently, and they are more likely to be cured. So it has a better prognosis than the cancer caused by other agents. So therefore, it is important when there is a patient with an oropharyngeal cancer patient to test for HPV in the cancer cells is very important. Unfortunately, we don't do it routinely. There is one pathologist when she was finishing her studies here at the University of Rwanda, I think 3 years ago. She had done a research to see what is the rate of HPV-associated oropharyngeal cancers in Rwanda, and you have seen 18% of orosquamous cell carcinoma in the oropharynx in Rwanda. They are due to HPV. So these ones may be treated differently. For example, one is treated with radiotherapy, another one is treated with chemotherapy. So whether it is caused by HPV or not. And the prognosis, as I said, is better when this cancer is caused by HPV than when it is caused by smoking or other problems. So these lesions caused by HPV are commonly finding in the patient with RA HIV infection, meaning not yet in the AIDS stage. They appear as warts. So warts ni cauliflower or choufle. So we call them condyloma. Condyloma when especially in the anogenital areas, we call them condyloma acuminatum. When they are called condylomata acuminata. So they have raised cauliflower-like appearance. So when you see it, you can say it is a cancer. but they are not cancer, but they behave like cancers, although they don't kill. Any question about AIDS manifestation in the oral cavity? Okay, we proceed with cystic and fibro-osseous lesions in the oral cavity. So cystic lesions, I think I mentioned them. We have many types of cysts. And cysts ziratandukanye cyane mu buryo zibaho, their origin, on how they behave, and especially on their consequences. So that's why then the histology usually will not give you a final diagnosis if you have not given enough history, enough findings. So the history of the patient, the findings clinically and by imaging. So these are very important for us to give a final diagnosis. So there are some of these cysts which will be having as complications cancers, others will be complicated towards other types of diseases and so on. So it is paramount to know what exact type of cyst the patient is having in order for you to plan for future interventions. So the first one here to discuss, we will discuss some of them. So here we have a list: odontogenic keratocyst, lateral periodontal cyst, dentigerous cyst, nakunze kubivuga ko iva cyane cyane mu bantu bafite impacted bone, kandi iyo itavanywemo then it will progress to kuri tumor bita ameloblastoma, and then ameloblastoma sometimes can be complicated into carcinoma. I saw some cases as such. Ariko ameloblastoma yo irahari nyinshi cyane ngaha. There's a nasopalatal duct cyst, radicular cyst, and so on. So what information do you have to know or to provide to pathologists or to any other healthcare professional you are discussing with? The first question they will ask you, is that cyst multilocular or unilocular? Multilocular meaning there are many pockets, or it is only one pocket. In that case, you could say unilocular. So there's a mistake here. Unilocular, not locular. So its location, is it around the root of the tooth, or is there any impacted bone or not? What is the shape or the size of that cyst? Does it have a risk for recurrence, or did it recur if you have removed it before, or somebody, some doctors have removed it before? Is that history there? So niba yarigeze kurwamo ikaba yagarutse. So other things will be predisposition, age, gender, and ethnicity, because there are some regions which are more seen in males, others in females, others in children, others in older people, others in blacks or whites, and so on. So the classification of cystic lesions of the oral cavity. So you can classify them according to etiology. That is one. In that case, you will say this cyst is inflammatory or is developmental. So what are the developmental cysts? We have the dentigerous cyst. Developmental meaning there has been a mistake in the embryogenesis and so on. Eruption cyst, odontogenic characteristics, and so on. So inflammatory cyst, there are periapical cyst, residual cyst, periodontal cyst, and so on. So this is a classification by etiology. Then the classification by tissue of origin. They can be derived from dental lamina or the rest of cells. There's the ones that are odontogenic keratocysts and so on. It can be derived from the rest of cells. I think these are the terms you have to remember from your course of embryology. Here we have a periapical cyst and a residual cyst, and there are others which are unclassified, so meaning nobody knows their tissue by origin. We have a periodontal cyst and calcifying odontogenic cyst. So we discussed some of them. The dentigerous cyst that I mentioned before. It results because of the enlargement of the follicular space of the whole or part of the crown of the impacted or unerupted tooth, and it is attached to the neck of the tooth. So you understand why I said it is important to know the location of the cyst. So you see here that it must be attached to the neck of the root of the tooth and not to the root of the tooth. And the patient must have a history of an erupted tooth. So here we have a clinical manifestation of it, but on the radiology, it is where it is very informative. So we have a cyst here. This is an impacted bone. You see that it has not erupted on the surface. It is still inside there, and there is a cyst around it, around the neck of that tooth. So this is the root of this normal tooth. The neck should be around here. So it is where exactly we have the cyst. It is at the So the skipping line, it is here where you see it is the whitish here. This line, it is like a capsule of this cyst. So eruption cyst is defined as odontogenic cyst that surrounds a tooth crown that has erupted bone, but not soft tissues, really kind of visible as a soft fluctuant mass on the alveoli. So ahanga bivuga iki iryinyo ryarashatse kumera riva muri bone rirazamuka. In a difference to what you see we saw on the dentigerous cyst. Okay. So in a difference to what we saw on the dentigerous cyst, whereby the tooth is still just below the soft tissues. Here the bone erupted from the bone. The tooth erupted from the bone, but has not gone beyond the soft. Tissue, so is not seen on the surface. Ariko iyo ureba ubona ko hari ikintu kibyimbye kiri munsi ya gingiva, for example, ukamenya ko ari iryinyo ryaheze aho ngaho. And here clinically see it here is blue on this area. So another one is the odontogenic characteristics, and this is very it is very important to know this disease, this cyst, because they say that it is associated with risk to develop cancer. So it is derived from the remnants of dental lamina. So what we see on histology, we must see that it is lined by squamous cells in 6 to 10 layers. And those at the basal layer, they are palisading, no kuvuga kuriya bubakaga bashingaga ibiti, bubaka urugo rwa kinyarwanda, kuriya ibiti bigenda bikurikirana, iyo twita palisading. So here you will see the cells trying to make something looking like a fence. There will be a parakeratin on the surface. Ngirango no hari tutsena jambo kerato, cyst keratin. So it has a keratin on its surface and so on. It may occur at any age, ariko bikunda kugaragara hagati ya second and third decade. Kuva ku myaka 11 kugera ku myaka 29 30 aho ngaho. Predilection for occurrence is in males. And you understand why we said when I started this part that it is important to say if the patient is male or female, the age and so on. Now we see the reason. The common site is the third molar area. This is also very important. So if you have a patient with a cyst, It is on the third molar area. He's a male around 20 years of age. Then think about odontogenic keratocyst. So other features are that it is painful. There will be swelling of the soft tissue around, the expansion of the bone, and the neurological or manifestations such as paresthesia of the lips. So I think around the gums here there is a redness, maybe because of the inflammation. But on the X-ray you see that there is a cavity here, which is clearly seen. So lateral periodontal cyst. This is a slow-growing, non-expansile developmental odontogenic cyst derived from the one or more rests of the dental lamina, containing an embryonic lining of 1 to 3 cuboidal cells. Of course, this will be seen on histology. There will be focal thickenings, and the predilection is also in males. The site will be mandibular, with cuspid or incisor areas. So you see that it is not just on the third molar as we saw for the previous, the odontogenic keratocyst, which is in the third molar area. These are not there. Also, they affect males, as we saw for odontogenic keratocyst. So there will be a radiolucent area in opposition to lateral surface of the tooth root. So you can see it here. Radiolucent, it means nahanwana hatari Hiv. Radio opaque, it is where it is whitish, like it is bony. Periapical cyst results when the rest of molar cells in the periodontal ligaments are stimulated for tooth. The tooth is painful because there's that time. There can be an acute exacerbation which leads to abscess formation. You can get cellulitis and so on. And even fistula, meaning pus is discharging through the oral cavity or through the skin. So here they have shown a tooth. Urabona ko risa nkaho riregarega kubera ko ntabwo riri ku murongo nk'ayandi. But what is the reason? The reason is that there has been necrosis in the periapical area of that tooth. So meaning umuzi waryo waraboze cyangwa around it there is a very soft tissue because it is necrotic. Periodontal cyst is an inflammatory cyst which develops on the lateral surface of the tooth root. So here tumaze kubona around the pulp, now here it is around the root. It occurs in young people seen in the third decades of life. See the decades between 20 and 30 years. Also males more affected. It is sometimes or usually associated with third molar as we saw for odontogenic keratocyst. So bivuga ko uyu muntu iyi ngiyi ihuje neza ibintu byinshi bihuje na odontogenic keratocyst. The difference now will be seen on histology. So you can see cyst here. So there's where cyst. Apart from them, now we have other lesions, fibro-osseous lesions. So if you have a question, you can ask, otherwise we proceed. Okay, so the fibro-osseous, meaning like these are not soft. The cysts are soft because they are filled with fluid. or just air or pus and so on. So fibro-osseous, they have a part which is fibrous, fibroblastic, and a part which is bony. So we have different diagnoses: fibrous dysplasia, osseous dysplasia, and ossifying fibroma. So iri jambo dysplasia hano mugomba kuryitondera. It doesn't refer to dysplasia we saw in carcinogenesis. It just refers here in this condition no uburyo tubona bone fragments and soft tissues, how they appear. So it has nothing to do with atypia or dysplasia as a precancer lesion. So now to have a diagnosis also you need to know the location, the age, the sex, and the race of course, if black or white. So here we have not listed them ariko ngira ngo ibindi bitangwa kuri details are histology. They are just those who will do pathology will have more details here. Otherwise ni indwara clinically zirasa, radiologically ziba zisabona ko it is a fibrous region, ukabona ko ifitemo some parts are bony, others are not, especially here. Let's look here. So see that there are whitish areas. This meaning they are rich in calcium, so they may be bony parts, but you have also blackish areas which are poor in calcium, so they can be fibrous areas. So this is how it will appear, but on the radiology you will not be able to distinguish the fibrous dysplasia and the ossifying fibroma. And it is important to know the final diagnosis, because the treatment options and the risk for recurrence and the prognosis will differ between both diagnoses. So we will end this presentation with developmental disorders. So what are the types of developmental disorders? Angawe turavuga ku menyo cyane cyane and other things in the oral cavity. Otherwise, the last time we saw other developmental disorders associated with Down syndrome and other syndromes which affect the head and the neck. So we'll not come back to that. And you know, I think this I had explained last time. Inherited disorders is the disorders a person gets from the parents, the genes. A congenital disorders, it means a disorder someone is born with. This can be hereditary, inherited or not, because it can be acquired in utero. If it is acquired in utero, this is not inherited. Inherited means it is caused by defects in some genes from your parents. So genetic factors, malformation due to a genetic factor such as chromosome abnormality and so on, and the environmental factors, we call them teratogens. And this, they are those who will cause some defects, developmental defects, but are not inherited. So they can be just teratogen in communities. If, for example, a mother takes some drugs, and when she's pregnant, then the child may develop these disorders. And then in such case, the drugs she has taken will be called teratogens, teratogenics or teratogens. So developmental disorders will have exostosis. This is the overgrowth of a bone. Muzamubona n'abantu bafite nko ku maboko bikunda kugaragara mu Kinyarwanda niba bita inkabya, kwa nara kanu kabyimbye gahoraho aho ngaho kagenda gakura uko akura, cyangwa se ari umwana ntikagaragara ariko kaba kujya gakura. So here we have them in the oral cavity. Yamwibyo twabonye torus palatinus, twabonye kandi torus mandibularis, which is bilateral as we saw them before. So there is overgrowth of the mandible bone here. Here it is overgrowth of the maxilla bone. So it can be called a torus. So the types of developmental disturbances of the jaw, lips, palate, and the tongue. So hari ibyo bita cleft lip and cleft palate, bamwe ibibari, hari ibibari bifata iminwa gusa, hari no bijyana na palate. Urabona palate no bituma izuru, izuru rikominikana no mu kanwa and so on. I think you see mu mwumva n'amatangazo kuri radio bavanga abantu bafite ibibari bazajye ahantu runaka bafite bazabavura. So it is a surgery done in multiple steps and so on. So ankylosing mu gifaransa bita frelengwa, muziko munsi y'ururimi hari akantu gafata ururimi, ni bisanzwe, ariko hari ugira akari tight gafata ururimi rukaguma hasi cyane ntushobore kuzamuka. So umwana ntavuga icyo gihe. So that's why when a child is born, there are things you must examine, including this. Kuyo mukabonye hakiri kare muragaca, hanyuma kuyangwa azavuga. Otherwise ururimi rutazamuka ntabwo umuntu ashaka kuzavuga. So hari ibindi ugomba kwexamina, hari abo kandi bafite utundi defect, anus ntifunguye, vagina ntifunguye and so on. All these things must be checked at birth. When I was working in this hospital, I received a child. She was around 7 years of age, and the mother just came saying, "My child doesn't talk." And when I just examined, I found it was ankylosing, and I was very much upset. A mother having a child for 7 years, and she doesn't at least observe that there is this tendon, if you can say so, which is causing problems. So birumvikana kuruca ntabwo bivuga ko umwana avuga. The speech is something which is also having a nervous almost benign. We consider it as the intermediate between benign and cancer because it has some characteristics of cancer, but on histology, they are just benign cells. There are people who have a supernumerary teeth. I think is what is shown here. So abantu bafite amenyo arenga 32 bakuze. cyangwa se umwana urengeje amenyo 20 kandi akiri umwana nawe ari afite supernumerary teeth. Macrodontia, one tooth can be very large, and micro it will be when there are small teeth. Densely dentate tooth within a tooth results in the formation of small tooth-like mass of enamel and dentin within the pulp. So this can happen, and you understand you will see it on X-rays. Okay, so disturbances in the enamel formation, abantu bagira amenyo atari umweru kubera hypocalcified, which hypocalcification bituma bagira icyo bita amelogenesis imperfecta. No kuvuga amagambo mwumva cyosobanura there is imperfect development of the bone of the tooth, or enamel of the tooth, not the bone. Hereditary abnormality in which there are hypoplasia type defects in the enamel formation, and the others hereditary enamel hypoplasia and so on. So these can exist. You can see some of such patients. So abnormal eruption of the tooth, we have ankylosis of a deciduous molar. So no kuvuga ko uyu bwayo ryashoboraga kumera ariko ryafatiwe ahantu. This word ankylosis refers iyo hari structure imwe yafatiriwe ku yindi structure. So for example, uzayibona umuntu afite wenda joint itagikora kubera ko bone tuvuge tibia na femur yarafatanye cyangwa rotire byarafatanye noneho ku buryo ivi ridahinika, icyo gihe avuga ko afite ankylosis there. And another example of ankylosis we saw is on the tongue. So here then the tooth had to erupt, but it didn't happen because it was entrapped within the bone. So impactions nabwo kare cyane amenyo atarameze. So premature eruption is inattive if there is a native present at birth. So ngira ngo mu Kinyarwanda bavuga ko umwana uvukana amenyo hari uburyo babyita bino by'imigenzo cyangwa imico y'Abanyarwanda, wangara ni arakungura and so on. So hari n'abamera amenyo bakiri bato within 30 days of life, because neonatal period no kuvuga kuva umwana avutse kugera amaze ukwezi nibyo bita neonatal period. Muzi ko umwana atangira kumera amenyo nyuma ntabwo ahita yamera cyane. Ankylosis, I mentioned this. Impaction also I have mentioned. So other additional disturbances in the tooth development and eruption, variation in the form includes extra, missing, or fused cusps or anomalies of the roots and so on. So there will be a missing part of a bone and so on. Hutchinson's incisors are a variety of peg-shaped teeth usually associated with maternal syphilis, meaning that a child will have this if the mother was having syphilis while pregnant. Fusion is the joining together of the dentin and the enamel of two or more separate developing teeth. And you understand? Namenyo abisa naho hari rimwe niba ntushaka gukura rimwe ngo reke irindi and so on. Germination is an attempt of the tooth bud to divide. So someone has one tooth and that tooth wants to divide itself into two teeth. So this is called germination. So abrasion is the abnormal wearing away of a tooth structure, and it is caused by a repetitive mechanical habit such as improper tooth brushing. So must know how to brush your teeth. It can be caused by other mechanical issues. Hari abantu bahora bahekenya ibintu cyangwa bahekenya amenyo abanyamujinya and so on. Ibi byose bigira ingaruka on the way their teeth appear. Attrition is the normal wearing away of a teeth structure during mastication. chewing. Bruxism is a neural habit consisting of involuntary gnashing, grinding, and clenching for the teeth in movements other than chewing. So hari ababigira baryamye, abantu benshi babigira kubera stress. So it is something related to psychology. So abrasion of the cervical area of mandibular premolar caused by tooth brushing, bruxism caused by attrition of the mandibular anterior teeth, and then attrition of adduct dentition. So miscellaneous disorders, hari ibyo bita bulimia, ni abantu barya cyane bavuga ko bafite bulimia. Food, so bafata ibiryo byinshi, ariko akenshi ibi biba ku bagore cyangwa abakobwa. So it is a psychological problem. Ngira ngo hari ibintu bibiri bashobora kugira, iyo bita anorexia nervosa. Ni ukuvuga anorexia, ni ukutagira apeti. Nervosa ni ukuvuga bituruka mu bwonko, umuntu yabyishyizemo, umwe bishaka ko atagira apeti. Icyo ni kimwe. Ikindi ni bulimia. Bulimia arya cyane atari kugira ngo agire ibimutunga byinshi arya, ahubwo ari kugira ngo narya byinshi aze kugira vomiting. Ibyo byose navuze ko bikorwa n'abagore n'abakobwa, akenshi bashaka kunanuka and so it is most seen among them. So all of them, they are psychological issues. So thank you. Any question?
Lecture.
Yes.
My question is about the causal agent of Coma.
Sorry?
What is the agent? What is the causal agent of Coma?
Capacitor. I said it is caused by a virus called the Capacitor herpes virus, which is also called the human herpes virus 8 or HHV 8.
Thank you.
Okay. So if there are no further questions, then we break for 10 minutes and we see another presentation. So someone asked, sometimes someone gets blood from gingival eating and brushing the teeth. What is the cause of that? You understand, it is a trauma. If you traumatize the gingiva, the gingiva is vascularized. So to have bleeding, it is like a normal. Of course, if it is more than expected, it can be due to other problems. Now to investigate the clotting factors, the platelet counts, are they normal? So you must go further to look into that.